Sakiti?
Yes, ma'am. Yes, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on women's health, organized by TNFOG. So it's my privilege to introduce the moderator of today's webinar, Dr. Gayatri ma'am. I request Gayatri ma'am to take over the session.
Thank you, Sahiti.
Yes, Gayatri.
We've been conducting this marathon CME very successfully for some time, and now I request our secretary, TNFOG, Dr. Sampath Kumari, to introduce the CME to the delegates as well as the chief guests.
Thank you, Dr. Gayatri. Yes. Good evening to Dr. Usha Madam, Dr. Rosa Madam, Dr. Revati Madam, and Dr. Ramani, and all the faculties and delegates. This is the TNFOG Marathon CME conducted every month in the second Friday. That is from 4:30 to 7 o'clock. We have 3 sessions. First session being the UVA session, second is the update, and third is the panel. The UVA session, it will be conducted for 12 months, and the same judges will judge the UVA's talk, and we will give the best UVA orator in the annual conference. The same judge will be there for 12 months. That is the UVA session. And the update we will be giving to the seniors. And the consent topic, we have the panel discussions. Since it was World Health Day on 7th, we thought this should be connected with the health. So it is the topic will be based on women's health. So I should thank Dr. Usha Madam and Rosa Madam to accept as chief guest and guest of honor within a short period of notice, I think. Now we will go with the Tamil Thai Valthu and the lamp lighting. Yes, Sahiti? Yes, Sahiti, lamp lighting. Yes, thank you. Now I request our President, Dr. Ramani Devi Madam, to introduce our chief guest. Dr. Ramani Devi Madam is our current President of TNFOG and the past Vice President of FOXI, and she is commonly known as endometriosis lady. Yes, Madam.
Sagiti Share Madam's CV, Usha Madam CV. I am very much honored to have Dr. Usha Sharma Madam today as chief guest for today's program. She's been awarded Padma Shri Award by the President of India in 1985. And she has been the past ex-director of General Medical Education, Uttar Pradesh, principal cum professor of gynecology and obstetrics from LLRM Medical College, Meerut. And she has won so many innumerable awards and many lifetime achievement awards, patron awards, and achievement. She has, right from her beginning, right from her undergraduate student days, she has won so many gold medals in almost many subjects and she has been awarded the President of India's Best Medical Girl of the Year in 1965. So apart from this, she has been awarded a laparoscope by the Prime Minister, Mrs. Indira Gandhi, for her outstanding work in 1982, and she won the Indira Gandhi Priyadarshini Award, Mahila Ratna Award, Meerat Ratna Award, Hari Om Ashram Olympic Research Award by President of India, B.C. Roy National Award, and Mahila Jyoti Award, and nominated as member of Consultative Group Planning Commission, Government of India, nominated by Government of India as an advisor for health and family welfare, Rashtriya Ratna Award and Gold Medal, and Jewel of India Award and Certificate of Merit, and late Professor Dr. Kutty Lifetime Achievement Award by Foxy, and Foxy late R.B. Dr. S.N. Malhotra Award, and member of Medical Council of India, and Chief Investigator for Human Reproduction Research Center, ICMR, New Delhi, and Golden Educationist of India Award, and Star Award by Pune Society, and ICOG Vidya Vibhushan Award by recognized work dedicated to ICOG. And I think if I start talking about her merits, the whole program
I
will
think
be
it's
covered.
enough. It's enough.
Madam, but you are one of the most respected persons, I should say, in Foxy. And I am really very glad to welcome you as a chief guest today, and welcome you to our marathon CME that is being conducted by the TNFOG. I think this is the last marathon CME what I am conducting as a president of TNFOG. This month end, I'm going to hand it over to the subsequent president. So that makes me really much more happy. Over to you, madam.
Thank you very much. Am I audible?
Yes, madam, you are very well audible.
It really gives me a great pleasure to be with you all on the occasion of TNFOG Marathon CME on Women Health. At the outset, I would like to thank and express my gratitude to the organizers, especially Dr. Sampath Kumari and Dr. Ramani Devi, to invite me to be amongst you all and to address this August gathering of eminent gynecologists of Tamil Nadu. Today, we know that the president, Dr. Ramani Devi, Dr. Sampath Kumari, who is the secretary, and Dr. Shravan Kumar, who is the treasurer. And I can tell you, Dr. Ramani Devi and Dr. Sampath Kumari are so dedicated, learned, down-to-earth person. And this time when in AICUG I met Dr. Sampath Kumari, I can tell you I was really impressed that how a lady with great humility, all the time she was with me to help me. And thank you very much, Sampath, for everything you did for me at Bombay. So I know that we have today 3 sessions. First session is the Yuva session. And in Yuva session, the judges are Dr. Shanti and Dr. Karthika. And then we have got the another session. And Yuva session, we are having precocious puberty and premature ovarian failure. And the other session is update on women health. And the last session is post-menopausal bleeding. I would like to just congratulate all the learned speakers as well as the panelists, the worthy chairpersons and moderator, and our master of ceremony, Dr. Gayatri, who will be just conducting the whole session. So all of us know that WHO has declared women health in India as a national priority. And we have been able, no doubt, we have been able to reduce the maternal mortality in many states, but still we lag behind the targets put by WHO, Ministry of Health and Family Welfare, as well as Government of India. And we have to do a lot more in this direction, because today maternal mortality is 97 per 100,000 live births, but we want to bring it down to 70. And so we have to really work hard, but for that, we will have to work together, then only we will be able to do something. Now, nowadays, initially, women health was just a synonym like maternal health. But nowadays, it is Sampoon Swasth of a lady, where we have to take care from her adolescence to menopause and beyond. That means that we will have to take care of a girl from her first dimple to her last wrinkle. So it is our duty to look after their health all through, because only maternal health will not take us to all the things which we desire. And that is why it is very, very important to have such CMEs. And I would like to congratulate the organizers. They have selected. I was really impressed by the academic content of this CME, because all the contents are so important in our day-to-day practice. And sometimes the results about the diagnosis and management are absolutely disheartening and depressing, not only for the patients, but also for the clinicians. And that is why it is very, very important to have such CMEs regularly, so that everybody can just repeat and remember things. And I'm sure that it will be a great learning experience for everyone. And this year, all of us know that our president, Dr. Sunita Tandulwarkar, she has got one motto, that Ek Rashtra, Ek Mission, Swasth Nari, Samradh Vatan, Ghar Ghar Foxian. So let us all join together, because till we join together, until we just coordinate with all the programs of health made by the government of India or ministry or WHO, it will not be possible for her to achieve the targets. And so let us join together so that we can have a progressed India, a united India, and a healthy India. And Dr. Ramani and Dr. Sampath Kumari, again, I will congratulate you that your content are so good. You know, even that postmenopausal bleeding, though it is such a common thing, but many times it's not diagnosed properly, and sometimes all the time, go for hysterectomy, go for hysterectomy. So, you know, these things are very simple topics, but have to be discussed again and again, because there are so many advancements coming in every field. We can give the advantage of those advancements through our specialty, through our knowledge, through our competence, so that our patients are greatly benefited. Thank you very much once again. And I'm sure that this program will go a long way in updating the knowledge of each and every obstetrician and gynecology who is attending this CME program. And I wish this program a great success. Thank you very much once again, Dr. Sampath and Dr. Ramani Devi, for making me a part of such a prestigious web CME. And I'm sure that all of us will work together, and will certainly, there will be one day when we will achieve our targets, and that will be the happiest day for every one of us. Thank you very much once again.
Thank you,
so
Usha
much,
madam,
Usha
for your kind words of blessings. And I'm sure already Tamil Nadu has achieved goal
Yes.
of less
Yes.
than 50 per 1 lakh in different areas. So I think we should achieve more and more. It's only a teamwork. We should do the best care what we can give for the women folk. Thank you, madam.
Thank you.
Thank you, madam. Madam, today is also Safe Motherhood Day.
And
Yes,
I
yes, I
just
know that.
forget my very pretty, beloved, dear friend, Dr. Rosa, who is guest of honor today. And I can tell you, she is a lady with beauty and brain. Whenever I see her, you know, I really get so much of energy and love and affection for her. I just forgot her name because I was just seeing towards Ramani and Sampath. And Rosa, it's so nice to meet you. I can tell you, you are a lovely personality and a very affectionate person. And of course, a very competent gynecologist.
Thank you so much, ma'am. I really enjoyed hearing what you were saying. Thank you so much for being here with us. Thank you.
Madam, Usha madam is mother of Foxy. Rosa madam is beauty of Foxy.
Adolescent of Foxy. Adolescent of Foxy, madam.
Ma'am,
Beauty.
let's now take the
Yes.
pleasure of introducing her, ma'am. She'll be introduced
Yes,
by
put
our
the CV.
beloved secretary.
Yes. Good evening, madam. I welcome, thanks to Dr. Usha Madam, and I welcome Dr. Rosa Ulai Madam, who has accepted to be the guest of honor. And she is the director of Ulai Hospital, and she is the board of membership committee. Madam, I have joined in the cell phone, so I will tell whatever. She is the first president of Foxy 2014, and she is representative board of trustee HUQUQ South Asia 21 to 22, and chairperson adolescent health committee Foxy 2012. She had 4 years to work in the adolescent. Yes.
Sampath, can I speak rather than I think it's all right.
Yes,
Thank you
madam.
so much.
So, madam, yes, stage
Yeah,
is
thank
yours,
you
madam.
so
Rosa,
much.
madam.
Thank you so much. First of all, it's such an honor to be, at the same platform as Madam Padma Shri, Dr. Usha Sharma ji, who is the mother of all the Foxians and a genuine lady who loves and encourages. Few days back, I had a call from her, and I still remembered her motherly love and regards that she gave me. It's really a pleasure, ma'am, and I really enjoyed hearing what you said from the depth of your heart. She has given a beautiful outlook towards the whole thing, but at the outset, I would also like to put on record and thank Professor, the immediate past president, Dr. Revati Janakiram, who's here, and the present president, who's Dr. Rama Devi, I think the endometriosis lady, who's known. I worked with her as a chairperson, and my very, very dear Dr. S. Sampath Kumari, who has been working diligently. I must say, Dr. Usha talked about health and everything, but I want to say my experience with Tamil Nadu. When I was a chairperson of Adolescent Committee, my coordinator was National Coordinator for the South Zone was Dr. Sampath Kumari. And we did together a beautiful study over more than 10,000 young girls in schools. And this, Madam Usha, has been published in PubMed. And Sampath was a key person who helped with the statistics and data. You won't be surprised to know that most of the girls from Tamil Nadu schools, way back in 2012, they wanted to learn more about spirituality and mental health. I'm talking about 2012, the study talks about. Now, things have become much more different because Sampath now has taken over the committee after me and others. And she has done excellent work as making even helpline for Tamil Nadu girls, which none of us had done that. So I think the government of Tamil Nadu was well cooperating with her doing all these activities. The topics that you have put today, Sampath, and the whole team together is from adolescent, from youth to menopause. That itself talks about the importance of, as Madam said beautifully, adolescent to menopause age, which brings about, at this era that we are, a lot of mental health issues as well. Issues that, they may be having endometriosis, they may be having PCOD, but as that affects them mentally, and depression is something which is there, whether you're in adolescent age, youth, or menopause. At each stage of life, we all have faced our own challenges. And I think here you've involved a beautiful young team of doctors. I know you said just now, you've got more than, I think, 5,000
It's
members.
incredible.
It's incredible that you have been doing these marathon. I mean, the title really satisfies, saying it's a marathon kind of a thing. And we are the last ones, at this episode that you're together. And you're giving certificates, and I just came to know that to all the participants. Keep up the good work that you're doing. And I think Tamil Nadu has to come up at the national level. We need to have representatives from Tamil Nadu who have to come up and take leadership. Why not? You have such beautiful medical colleges. You all are such beautiful people with academics right on the top. And I think I would like to wish my dear Sampath, Dr. S. Sampath Kumari, all the best for your presidentship for year 2026. I think I would like to announce that, Madam, she's appearing for a candidate, and I think it's really deserving. We need to have somebody from South and
Absolutely.
who represent Tamil Nadu
Thank you,
on the
Thank
bridge.
you. Thank you.
So all those who are together with us, we would like to cheer you up and wish you all the very best of the Sampath. Thank you so much for this opportunity to be with all of you. And of course, my dear young Priya, somewhere she is, I can't see her. She's your associate professor, I think. She's somewhere here. There are so many names, but no pictures, so I can't mention anybody. My best wishes for today's CME. Thank you for inviting
Thank you, madam.
Thank you.
Thank you, Rosa madam. Thank you, Usha madam, for being the chief guest and the guest of Thank you so much. Dr. Gayatri, you can
Thank you
take
very
over
much.
for science.
Thank you very much. With this, we'll move on to the first session, the Yuva session. We have had our judges for the Yuva session who are constant, Dr. Shanti and Dr. Kartika Prabhu. Dr. Shanti, she is a professor, Department of OG, Savita Medical College and Hospital in Chennai. She did her MBBS from the Madras Medical College and MD from the same Madras Medical College. She's trained in ultrasound, advanced infertility, laparoscopy, and she also provider and instructor courses. She has a lot of publications to her merit, and her field of interest include endoscopy, high-risk pregnancy, and adolescent gynecology. She's been an examiner for the UG and PG for quite some time, and she's also one of the invited faculty in a lot of conferences, and she also has organized a lot of national and international conferences. Over to you, ma'am. With her, we have Kartika Prabhu, Dr. Kartika Prabhu, who's the professor in SRM Medical College and Research Institute, Katangulatu. She did her MBBS from MMC and MD from JIPMA. She's been an undergraduate and postgraduate teacher with a special interest in high-risk pregnancy, gynec endoscopy, and midlife health. She has a lot of awards to her credit. She also has a lot of publications, more than 20 publications, and she is also a faculty in out of regional and national conferences. Over to the judges now.
Kartika,
Yes, ma'am.
tell the rules, ma, for the UAs. That is 12 minutes and 3 minutes. Please inform them.
Yes, ma'am. So now I invite the first speaker, Dr. Preeti, who is Assistant Professor, Department of Obstetrics and Gynecology from Dharmapuri Medical College. She'll be giving the talk on precocious puberty. So your time is 12 minutes. You have to finish your presentation within 12 minutes. Then the last 3 minutes, we'll be having a short discussion on that. You can start.
Thank you.
Good evening, ma'am. Is my slides visible, ma'am?
Yes, it's visible.
I'm going to present about precocious puberty.
You are not audible, ma'am.
Dr. Preeti? Dr. Preeti?
Precocious puberty is defined. There is development of secondary sexual characters before the age of 8 years in girls and 9 years in boys. It is classified as gonadotropin dependent, gonadotropin independent, and incomplete precocious puberty. First, gonadotropin dependent precocious puberty. It is otherwise called as central precocious puberty or true precocious puberty. Early maturation and activation of hypothalamic pituitary gonadal axis is the reason for central precocious puberty. It is usually isosexual. It is consistent with the child's gender. 90% it is idiopathic. And it also occurs in CNS lesions like cyst, irradiation, trauma, infection, septoptic dysplasia, in other tumor conditions like hematomas, astrocytoma, ependymoma, gliomas, penile tumors. Other causes like genetic causes, activating mutation in gene encoding GPR54 or KIS1R mediates action of kiseptins, an excitatory neuroregulator of generous secretion, or loss of function mutation in MKRN3 and DLK1 gene. Other syndromes like neurofibromatosis type 1, Stooge-Weber syndrome, and tuberous sclerosis are also related with central precocious puberty. Next is gonadotropin independent precocious puberty. It is otherwise called peripheral precocious puberty or pseudo precocious puberty. It results from exposure to sex steroid hormone derived from gonads, adrenals, or the environment. It can be isosexual or contrasexual. The causes are autonomous functional ovarian follicular cyst. It is the most common cause, or other ovarian tumors like granulosa cell tumor, Leydig cell tumor, gonadoblastoma, androgen secreting tumors, primary hypothyroidism, exogenous estrogen, estrogens, placental extracts, or other environmental pollutants like polychlorinated biphenyls, herbicides, pesticides, etc. will lead on to peripheral precocious puberty. Combined causes like congenital adrenal hyperplasia, virilizing gonadal tumors, or McCune-Albright syndrome will lead on to both peripheral and central precocious puberty. Next is incomplete precocious puberty. It is isolated premature telarchy or premature adrenarchy. It is usually a normal variant, but sometimes it can progress to complete precocious puberty. Premature telarchy, it is isolated breast development in girls before the age of 8 years, variant of normal puberty, and also it can present an early sign of McCune-Albright syndrome or due to exogenous estrogen exposure. Premature adrenarchy, it is the most common cause of premature puberty. Growth rate and bone age are above the average, but within normal ranges. Serum dihydroepiandrosterone levels are increased. That is more than 40 microgram per deciliter. Early variant of normal development. 20% girls, gonadotropin dependent precocious puberty. Increased risk of developing PCOS. Complications of precocious puberty is shorter adult life, psychosocial problems, obesity, insulin resistance, type 2 diabetes, hypertension, serious disorders, breast cancer. How to evaluate a case of precocious puberty? We have to ask the history, family history of precocious puberty, history of headache, seizures, or any abdomen pain, previous history of neurological diseases or trauma, history of exposure to any steroids. Next, undergo physical examination, height, weight, calculation of growth velocity, endoscopic examination for papillary edema to rule out increased intracranial pressure, evaluation of visual fields to rule out the cellular mass lesions, skin examination, cephalic spots or light lesions in McCune-Albright syndrome, Tanner staging of pubic hair and breast development, and measurement of bone and age if any signs of early sexual development is seen. Endocrine evaluation should be done in these cases in case of advanced bone age when it is more than 2 standard deviation, normal bone age with both breast and pubic hair development, and normal bone age with accelerated growth of breast or pubic hair development. The various hormonal assays which has to be done is basal gonadotropin levels, FSH and LH levels, serum estradiol, serum testosterone in boys, and GnRH stimulation test will be the diagnostic test. It can be done by giving 100 microgram GnRH IV or leuprolide 20 microgram per kilogram subcutaneous, followed by LH estimation is the most useful diagnostic parameter. In case of precocious puberty, the LH will be with the normal limits and there will be high sex steroid levels. When the baseline FH is more than 0.3 international units per liter or GnRH stimulation LH is more than 5 international units per liter, it will be diagnosed as central precocious puberty. Then MRI to exclude intracranial mass lesion, thyroid function tests, HCG for functional ovarian cyst and tumors or adrenal tumors, late afternoon cortisol levels to rule out Cushing syndrome, DHEA in case of premature adrenarchy, 17-hydroxyprogesterone in case of to rule out congenital adrenal hyperplasia, abdominal and pelvic ultrasound to rule out functional ovarian cysts or tumors. It is a evaluation slide. We have to estimate the bone age. When it is advanced, we can directly go on for GnRH stimulation test. If the basal and the stimulated levels are high, then it is considered as a GnRH dependent precocious puberty. In that case, we have to do MRI, thyroid, abdomen and pelvic ultrasound. When the levels are within normal limits, we'll go as independent precocious puberty. In that case, we have to estimate the estradiol, testosterone, HCG, 17-hydroxyprogesterone levels, abdomen and pelvis. When only the isolated breast and pubic hair has been abnormal, it will be considered as isolated precocious puberty, and observation and serial examination we can monitor like that. Next is management. In case of gonadotropin dependent case, after following MRI, if there is any intracranial lesion, we have to treat the lesion. If there is no intracranial lesion, treatment depends upon the pace of progression of the sexual growth and adult height. When to treat a case of precocious puberty? When the sexual maturation progresses to next stage within 3 to 6 months. In that case, we have to treat. when the growth velocity is more than 6 centimeter per year, or when the bone age advanced by 1 year, or the predicted adult height is less than target range or decreasing on serial determination, we have to treat the gonadotropin dependent precocious puberty by giving GnRH agonist. It is safe and effective method for treating the central precocious puberty. It acts by giving initial flare of gonadotropin release, followed by pituitary desensitization and downregulation. Default preparations preferred due to improved compliance. The preparations are Buserelin 100 mics, nasal spray daily, or Luprolite 1.5 milligram monthly or 11.25 milligram 3 monthly. Istilin 50 milligram implant lasting for 1 year. Triptorelin 11.25 milligram 3 monthly or 22.5 milligram 6 monthly. Other like medroxyprogesterone acetate 100 to 200 milligram in 2 to 4 weekly, cyproterone acetate 70 to 150 milligram per meter square per day can be used, progesterone, to stop the bleeding. It doesn't produce any effect on height. How we can follow at 3 to 6 months interval, serial physical examination and bone age can be estimated, and the treatment has to be continued until the epiphyses are fused or until puberty and chronological ages are appropriately matched. Independent precocious puberty or treated depending on the underlying pathology. In case of tumors, it has to be undergone surgical excision. HCG secreting tumors, we can go for adjunctive radiation or chemotherapy depending upon the type. Solitary lesions has to be removed. Congenital adrenal hyperplasia is treated by giving glucocorticoids. McCune-Albright syndrome is treated by giving tamoxifen anti-estrogen or aromatase inhibitors like letrozole, anastrozole. Bisphosphonates is supplemented for treating fibrous dysplasia of the bone, and GnRH agonist is also used. Highlighting the updates, newly the genetic mutation in KIS1R and MKRN3 and DLK1 has been found to be associated with precocious puberty. GnRH agonist has emerged as a reliable test for hypothalamic pituitary gonadal function. The effect of GnRH treatment of central precocious puberty on height is greater if the onset is before 6 years. To conclude, multiple physical and psychological conditions are associated with precocious puberty. Broad and comprehensive clinical approach and evaluation is needed to treat and prevent the associated comorbidities. Thank you, ma'am.
Good presentation, Dr. Preeti. Do you think there is increase in precocious puberty now?
Yes, ma'am.
Can you tell what are the causes, possible causes?
Obesity, ma'am. Nowadays, increasing trend of obesity.
Okay, any other factor is playing a role now?
EDC. In the era of cosmetics.
Yes, ma'am. Exogenous estrogen exposure.
So using of creams and other things, estrogen, creams.
Yes, ma'am.
And plus environmental factor also plays a role. So
Mainly
what is
receptors.
xenoestrogens?
Xenoestrogens. Yes, ma'am.
Can you differentiate central precocious puberty from peripheral precocious puberty from history-wise?
Yes, ma'am.
How you can differentiate?
Central precocious puberty, it will start too early, ma'am.
Actually, central precocious puberty, all the events will occur in sequence, like a normal puberty. What are the first? Telarchy occurs, then pubarchy occurs, then menarche occurs. Whereas in precocious puberty, the sequence may be there or it may not be there.
That is why it's called consonant puberty, that is central precocious puberty. When it is disconsonant, it is peripheral precocious puberty. Yeah. Then regarding the bone age, so generally we expect advanced bone age in almost all causes of precocious puberty. There is one exception. Can you say that?
McCune-Albright syndrome.
It is hypothyroidism where you don't expect the advanced bone age. Okay. So otherwise, the overall presentation was really good. Thank you so much, Dr. Preeti.
Yes, ma'am. Thank you, ma'am.
Shanti, you can introduce the next speaker.
Yes. Can I have the, yeah. So I welcome Dr. Shravani Chitra to have her presentation. She is currently working as assistant professor at Sri Muthukumaran Medical College and Hospital, and she has completed her MBBS at Chettinad Medical College and Hospital, and MD at from Annamalai University. She has completed her fellowship in reproductive medicine as well as in minimal access surgery. And she's written a chapter in Mastering the Techniques in Hysteroscopy by Osama Shaki. And she's contributed in preparing PowerPoint's presentation in the 13th edition of Mudaliar Menon's Clinical Obstetrics textbook. And she has a lot of publications, and she has been an invited faculty and made presentations in national and international conferences. So over to you, Dr. Shravani. Please stick on to the time.
Share my screen.
Our topic is on premature ovarian insufficiency.
Can I start, ma'am? Can I start, ma'am?
You can
Yes,
start.
please go ahead.
Good evening, everyone. My topic for discussion today is premature ovarian insufficiency. Did you know 1 in 100 women under the age of 40 years experience premature ovarian insufficiency? What would it mean if you were told your ovaries stopped working prematurely? What are the sequelae of POI? Is it genetic? Should the family members be notified? Is the treatment necessary? So there are n number of questions boggling our mind when it comes to POI. At the end of my presentation, I hope I can clear all these questions. The condition addressed was first described as primary ovarian insufficiency by Fuller Albright in 1942. Later in 2015-16, Eshrey has recommended that the term premature ovarian insufficiency to be used. POI is defined as a clinical condition characterized by loss of ovarian function indicated by amenorrhea or oligomenorrhea for more than 4 to 6 months, together with biochemical confirmation of ovarian insufficiency before the age of 40. It is a state of female hypergonadotrophic hypergonadism, and it can manifest as primary amenorrhea or secondary amenorrhea. And POI can be due to non-iatrogenic or iatrogenic causes. Going on to incidence, the incidence of non-iatrogenic cause of POI has increased from 1% seen in 2003 to around 3.5% by 2023. And in case of iatrogenic causes, there is incidence of 2.1 to 82.2% seen in childhood or adolescent cancer survivors, 35.53% incidence in chemotherapy-induced amenorrhea, and 0.5 to 6.8% incidence seen in women with endometriotic surgeries. There are two mechanisms that could cause premature ovarian insufficiency. One is the early ovarian senescence, in which women have an inherently small pool of ovarian reserve or quantity of primordial follicles endowed at the time of gametogenesis itself. And the other is the accelerated destruction of oocytes, which is seen in genetic and autoimmune causes or toxic substance exposure. There are various risk factors for POI. Genetic factor could be the cause, could be a risk for non-iatrogenic POI with a risk of 15.9%. When it comes to family history, the risk of POI is increased by 18-fold in first-degree relatives, 4-fold in second-degree relatives, and 2.7-fold in third-degree relatives. There is low risk in Asian women as compared to Hispanic, African American, and Caucasian women. Excessive smoking, drug abuse, poor diet can cause an increased risk. Lower body mass index has a 2-fold increased risk. The Interlace study has showed a 2.26-fold increased risk with nulliparity, which again doubles when it combines with early menarche. And there is high risk in women with low socioeconomic status. When it comes to vaccine, as of now, ACOG has recommended that there is no association between vaccines and POI. But when when HPV vaccine was launched in 2006, there were an increase in number of POI cases by 22.2 cases per year. Alcohol seems to have an inverse association with the age at natural menopause, and other risk factors include infection, autoimmune disorders, and chemical exposure. The symptoms, patient usually presents with irregular periods or complete cessation of menstruation, with 86% presenting with secondary amenorrhea and 14% with primary amenorrhea. Usually, these symptoms are transient or intermittent, reflecting that the fluctuation in ovarian activity happens after the onset of non-iatrogenic POI. And the other symptoms include vertigo, mood swings, anxiety, headache, palpitations, low sex drive, osteoporosis, joint stiffness, paresthesia, vaginal dryness, infertility, UTI, hot flashes, night sweats, insomnia, and cold intolerance. There are many causes of POI. They are iatrogenic and non-iatrogenic causes. The iatrogenic causes include exposure to chemotherapy with a high risk when exposed to alkylating agents and platinum-based agents, and moderate risk when exposed to anthracyclines and taxanes, and low risk when exposed to Vinca alkaloids. Radiation therapy, particularly if it is involving the pelvic, ovaries, and cervical processes like hysterectomies or non-iatrogenic causes include genetic factors like Turner syndrome, Fragile X syndrome with FMR1 pre-mutation, and hereditary predisposition to POI. Autoimmune disorders like autoimmune uveitis, Addison's disease, hypothyroidism with anti-TPO antibody positive, and SLE. In autoimmune disorders, the antibodies produced attack the pecan granulosa cells of the ovarian tissue, causing POI. In infections like mumps, HIV, herpes zoster, cytomegalovirus, tuberculosis, malaria, and varicella, and endocrine disorders like hyperthyroidism, hypothyroidism, and hyperprolactinemia. There are various metabolic and environmental factors like smoking, which could cause damage to the ovarian function, and obesity, which is linked with hormonal imbalances, idiopathic causes, and chromosomal abnormalities like Turner syndrome. The diagnosis is made based on two diagnostic criteria. One is the disordered menstrual cycle for at least 4 months and elevated FSH levels of more than 25 international units per liter. The blood test usually will show high FSH and low estradiol levels. Ultrasound will show low ovarian volume or a low antral follicular count. Anti-Mullerian hormone test can be done with has a diagnostic threshold of less than 0.25 nanograms per ml, but it is not used as a primary diagnostic test for POI. When it comes to autoimmune uveitis, the patients will present with high serum levels of inhibin B and normal or high AMH levels. Once the diagnosis is confirmed, the women are subjected to further investigations like karyotyping, FMR1 gene pre-mutation, adrenal antibodies like 21-hydroxylase and adenocortical antibodies, anti-TPO antibodies. If the autoantibodies are tested positive, then they are repeated every year. If they are negative, there's no need to repeat the test, but unless the patient becomes symptomatic. Utmost care is important for women because the was affected by your family dynamics. Is privacy should be given to the patient. Establish a good rapport with them, and you assess the current understanding of the patient regarding POI. Ask the patient what and how much information they would like to know. Break the bad news to the patient. Use simple words and language while explaining the condition. Check their comprehension. Identify, acknowledge, and empathize with the patient. Summarize your consultation. Allow questions to be asked by the patient and reinforce your next plan. This should be the care given at the time of diagnosis. There is implications for the relatives of women with POI. As already discussed earlier, the risk of POI is increased by 18-fold in first degree relatives, 4-fold in second degree, and 2.7-fold in third degree relatives. In 2019, a meta-analysis has shown that there is 15% risk of POI in women with relatives diagnosed with POI. POI causes a deleterious effect over the health and well-being of the individual by causing physical impact like menopausal symptoms, infertility, high risk of osteoporosis, and risk of cardiovascular diseases, and also emotional and psychological impact like anxiety, depression, cognitive decline, and social and relational challenges. So the main treatment options include hormone replacement therapy, fertility preservation, and lifestyle changes. And when it comes to hormone replacement therapy, the main goals would be to mimic the endogenous levels of sex hormones, to maintain the serum E2 levels of about 100 picograms per ml, continue the treatment until the age of natural menopause, and proper follow-up. When it comes to post-pubertal premature ovarian insufficiency, if the woman has no uterus, then estrogen therapy alone would be enough, which can be given as oral estradiol with a dose of 1 to 2 milligrams per day, transdermal estradiol at a dose of 100 micrograms, or conjugated estrogen. If there is an intact uterus, along with estradiol, medroxyprogesterone acetate, or dydrogesterone 10 mg per day, or oral or vaginal micronized progesterone 100 to 200 mg per day are added for 12 to 14 days every month. This addition of progesterone is mainly to reduce the risk of endometrial hyperplasia or endometrial cancer. Femosin is one drug, HRT drug, which is available in India, which has 14 tablets of estradiol and 14 tablets of estradiol and dydrogesterone together. When it comes to prepubertal premature ovarian insufficiency, here the goal is to achieve exposure to increasing estrogen levels in a progressive fashion over months, starting with very low dose of estradiol, like 6.25 micrograms per day of 17-beta estradiol transdermally, or micronized oral estradiol at 0.25 milligrams per day. And this is increased gradually every 3 to 6 months until the adult dose is achieved or the first menses ensues. After this, cyclic progesterone regimen is added, mainly for endometrial protection. Oral micronized progesterone of 100 to 200 milligrams per day can be added for 12 to 14 days. OC pills are usually avoided in prepubertal POIs. Follow-up is very important, and it is mainly followed by measuring the hormonal tests like FSH, estradiol, progesterones. DEXA scan is done to check the bone mineral density. For cardiovascular health, we have to monitor their blood pressure, lipid profiles, and growth and development is checked in adolescents by the signs of pubertal development and menstrual-like cycles. In certain special cases like Turner syndrome, endometriosis, HRT is a must, and it has to be continued throughout the reproductive lifespan. HRT is contraindicated in breast cancer survivors, but when it comes to women who are carrying BRCA1 or 2 mutations, they can be given HRT after prophylactic bilateral sapling oophorectomy, as long as they do not have a personal history of breast cancer. Migraine as per se is not a contraindication to HRT, but if they have migraine with aura, then we have to give low dose estrogen should be given. POI, fertility and pregnancy. So when a woman is diagnosed with non-surgical POI, they have to be informed that ovarian activity may occur, and they have a possibility of 5 to 15% chance of spontaneous ovulation and conception. And if the woman is diagnosed with chromosomal aberrations, they require preconceptional counseling. And IVF or ICSI with preconceptional genetic diagnosis, PGD, can help in reducing the transmission of genetic mutations. As of now, there are no interventions which reliably improve the residual ovarian reserve parameters, but recent interventional studies of novel approach have been done, aiming to enhance the fertility in women with POI. They are in vitro activation of follicle growth in biopsied ovarian tissue, administration of mesenchymal stem cells, and injection of platelet-rich plasma into the ovary. There are various fertility preservation options available for women who are undergoing who are going through POI. They are egg freezing or the oocyte cryopreservation, embryo freezing, ovarian tissue cryopreservation, which is experimental, ovarian transposition in case of women undergoing radiotherapy or chemotherapy, and donor oocytes if they're not able to conceive with their own eggs. It is very difficult for any woman with POI to cope with
you have 2 more minutes.
Yes, ma'am. To cope with the diagnosis and with the relatives and peer pressures. So the coping mechanisms and support is very important, which includes the mental health support like with counseling, support groups, and therapy. Building awareness to encourage to educate others, reduce stigma, and support individuals facing POI, and peer support. To conclude, majority of cases of POI remain idiopathic. POI is a state of estrogen deprivation that holds both short-term and lifelong implications for health and psychological well-being. Hence, timely initiation of hormone therapy and a multidisciplinary approach must be recognized as a cornerstone to effectively manage this complex entity to ensure that physical, psychological, and emotional challenges that result from POI diagnosis are met. So early intervention and understanding can make all the difference in managing premature ovarian insufficiency. Thank you.
Thank you so much, Dr. Shravani. So
Thank you, ma'am.
You have almost covered various topics, but then definition of POI. So
Yes,
it
ma'am.
is amenorrhea or oligomenorrhea with the measurement of FSH, right? It is not a
Yes,
single
ma'am.
measurement, right? So it should be
It is.
measured on 2
It should be
occasions.
measured at 2 times, ma'am.
Yeah, interval.
At around 3 months difference. So,
We have various guidelines for that. According to
guidelines,
NICE
yes, ma'am.
guidelines, it says FSH should be more than 30, measured 4 to 6 weeks apart.
4
And
to 6
ICHA guidelines
weeks.
says that it is 25, as you mentioned, and it should be done
Yes.
4 weeks apart. Okay. On 2 occasions, it should be documented, right? And regarding POI, it's not just the diagnosis and treatment. Okay, we need to find out the cause, right?
Yes,
Why
ma'am.
is it important that we need to know the cause of POI?
Because our basically, if suppose we have
It's going to be like hormonal treatment, right? So, but why then we need to know the cause?
when it comes to like non-iatrogenic POIs, mostly the patient the women will have reduction in the follicle count, ma'am. But when it comes to autoimmune conditions for POI, there is always a chance that because the granulosa cells a pool of granulosa cells will be still present in those patients, so there is always a chance for them to ovulate. So we can try to get their oocytes or help them with fertility preservation methods. So
And
once we
moreover,
diagnose, we can plan.
Yeah. So we need to find out the cause. As you mentioned, autoimmune causes would be the most common, right? So when
Yes.
it comes to autoimmune, we need to screen them for other autoimmune diseases, right? Like they
Yes.
can develop diabetes, like thyroid disorders. So we
Thyroid
need to
disorders,
treat
anti-TPO
yeah.
antibodies have
So
to be
we
checked.
need to treat the patient as a whole. Okay? And if
Yes.
it comes to the chromosome abnormalities like Turner syndrome, and like we need to screen them for cardiovascular diseases and all the stuff, right? And regarding HRT, how long we are supposed to give HRT?
Until the natural menopause age is attained, ma'am. For Indians, it is around 46.6 is taken as the guide according to the guidelines.
Yeah.
Usually it is between 45 to it is somewhere around 50 to 55, but for Indian population it is taken as an average of 46.6.
Yeah, so maybe up to 50 years, right? So in endometrial, the common surgical procedure, right? We do, for the sake of infertility, is the endometriosis cyst, right? Cyst
Cystectomy.
removal.
Yes,
So
cystectomy.
we need to counsel them regarding whenever you remove the cyst.
Whenever remove the endometriotic cyst, yes, and the AMH levels will tend to drop because the ovarian tissue can be affected.
Yeah, there is a risk of premature ovarian insufficiency. So around 2%. So we need to counsel that also. And in case of endometriosis, say we have performed like TH or whatever, the hysterectomy with BSO, that is the ultimate treatment, like in case of very severe illness. So how would be the HRT in that patient?
Same 1 milligram or 2 milligram dose of estradiol with dydrogesterone combination can be given to this patient until the natural menopause age has attained.
Uterus is not there, right? So why can't we give only estrogen?
Sorry, yes, ma'am. Only estrogen therapy will be given because TH with BSO has been done for her. Sorry.
So actually, that is the catch in the question. We are not supposed to give estrogen alone, okay? Because we know endometriosis is the presence of endometrial tissue elsewhere also, right? So anywhere in the peritoneum. So when you combine, when you give only estrogen, again, we are going to stimulate the tissues, endometrial tissues situated elsewhere. So we need to remember this. If this is the only exception, when the uterus is absent, still you give combined HRT. That is, whenever you perform hysterectomy with BSO, HRT to be followed. So we need to give only combined and not estrogen alone. Okay?
Yes.
Okay, thank you so much.
Thank you.
That was wonderful discussion in both cases. Thank you very much, judges and the speakers. You are speakers. Now we move on to the second session. To chair the second session on Women's Health Update, we have Dr. Yam Chandra Puniswamy, who did her UG and PG in Government Stanley Medical College. She's a gold medalist and she started the first laparoscopic and IVF center of her district, Namakkal. And she delivered the first IVF and ICSI baby of her district too. She has a lot of affiliations to her. She's a member of the FOXI, life member of IMA, ESAR, Image, IAGE, and PCOS Society. She's the founder president of Namakkal Women Doctors Association and Namakkal OG Society. She's been the EC member of TNFOG, registered ESAR faculty, and faculty in many national and international conferences. She has a lot of awards also to her credit. NEMA's Best Doctor Award and Best Woman Achiever Award, Best Fertility Consultant Award, and ESAR Dronacharya Award. Over to you, ma'am. Madam, Chandra madam? Chandra madam, are you there?
I don't think she's joined.
Okay, without wasting much time,
Gayatri, go ahead, Gayatri. Go ahead.
It's my pleasure
can
to
proceed.
introduce Dr. Revati Janaki Raman, who's the former director IOG Chennai. She's been the vice president FOXI South Zone 2016 and president TNFOG in the year 2023. She's the founder, secretary, and past president of the Madurai OG Society and founder president of Madurai Menopausal Society. She's a zonal coordinator in FOXI ACS HPV vaccine drive. She's got a lot of awards.
Okay, ma'am. Okay, thank you. Please give me the 2 minutes for my talk. I'll add in that. Thank you.
Thank you, ma'am.
Yes, thank you so much. Women's health is really such a vast subject, just like the old Kaveri. And like Agastya, who put it in the small pot, I'm going to put it in just a 20 minutes talk. Women's health is more than a concern. It's a catalyst for societal transformation and a beacon of empowerment. It's a clarion call to move beyond challenges and embrace the endless possibilities of a healthier, empowered future for women everywhere. Women's Health India 2025 aims to dismantle the inequities in healthcare access, awareness, and advocacy, forging a path where every woman, regardless of her background, has the resources and opportunities to live her healthiest life. So what are we supposed to do? What we should know? We need to manage medical conditions that are unique to women, which are disproportionately going to affect women and which may present differently compared to men to the women, which will necessitate tailored prevention and treatment strategies. We have to create awareness, especially about screening for cancer, breast as well as cervix, vaccination for adolescents and elderly women, and also make them realize that they should not ignore the symptoms and they have to avail the medical facility immediately. And we have to stress the importance of nutrition as well as exercise. When you take up cancer specifically for women, the breast, cervical, and ovarian cancer, creating awareness about the breast cancer and early detection are very crucial because it plays a vital role in educating the public about the importance of early detection, which increases treatment and survival. Cervical cancer prevention and HPV vaccination, we are talking every nook and corner about this, and we all know about this 90, 70, 90 goal of WHO, for which we are striving hard, knowing very well that still we are not reaching that, though we are creating awareness about vaccination to a great extent. But even for a long time, we are doing this awareness for screening, but still the percentage of screening is not to the expected level, which we have to concentrate more. And ovarian cancer presents significant challenges in detection, treatment, and survivorship, highlighting the importance of early diagnosis and comprehensive care. It's a silent killer because it can go unnoticed in early stages due to vague symptoms or even being symptomless. Targeted therapy and immunotherapy are the newer approaches that may be used in specific cases to enhance the treatment efficacy. Now, another area which we have to think is women's cancer survivorship and quality of life of women in them. Advances in early detection and treatment have significantly increased the survival rates for various types of cancer among women. We know that. So, women's cancer survivorship encompasses physical, emotional, and social aspects of life after completing cancer treatment, aiming to enhance the quality of life and overall well-being. However, survivorship brings its own set of challenges and considerations. Like physical health concerns may persist after treatment, like fatigue, pain, lymphedema, neuropathy, even menopausal symptoms, which is induced by treatment such as chemotherapy, radiation, or surgery. And emotionally, again, cancer survivorship may bring about feelings of anxiety, fear of recurrence, depression, or adjustment to changes in body image and self-esteem. These symptoms can impact daily activities and quality of life, which require ongoing management and support from healthcare providers. Here only we have to give a lot of support to the women. Supportive care, including counseling, support groups, and survivorship programs, all these things can provide emotional support and help women navigate the emotional challenges associated with the survivorship. Menopause, menopause transition, and menopause hormone therapy, about which we are talking a lot about, because we know that menopause is a significant transition part in a woman's life, and it involves a lot of changes, both physical and emotional symptoms. The common symptoms which we know are the vasomotor symptoms and the genitourinary syndrome, as well as the symptoms due to the bone health problems. Now, awareness about all these things and timely management will not only improve the quality of life, but also help prevent many future illnesses. Remember, MSG, still many are not coming forward to prescribe MSG for the genuine candidates who require them. And you have to remember this point that MSG started within 10 years of menopause and less than 60 years of age is the recommendation, and that is found to be very safe and effective. Pelvic health and urinary incontinence again encompasses the function and support of pelvic organs, including bladder, uterus, and rectum. Urinary incontinence is a common pelvic issue which impacts the quality of life. The risk factors all of us know, including the childbirth, pregnancy, menopause, aging, obesity, chronic cough, and certain medical conditions also. And we have to give them proper care to prevent these risk factors too. Sexual and reproductive health encompasses a broad range of issues which include access to comprehensive healthcare services that address contraception, fertility, STIs, pregnancy, childbirth, and menopause. Empowering choices in health, sexual and reproductive health involves ensuring that individuals have the information, resources, and support to make informed decisions about their bodies and lives. Key components are access to contraception and family planning services, and they should be able to choose the option that best suits their needs and preferences. Education, which is again very, very important for them to make informed decisions, and comprehensive sex education programs provide accurate information about anatomy, contraception, STI consent, healthy relationship, and reproductive rights. And such education helps dispel the myths, reduce the stigma, and promote responsible sexual behavior. This is still a vague area, but it has to be stressed. Maternal health, of course, as Dr. Usha was telling in the beginning, that women's health doesn't stop short with the maternal health alone, but still other things are there. And taking the maternal health, we have to ensure safe pregnancy and birth, which involves access to quality health service, support system, and educations to promote healthy outcomes of both mother and infants. Adequate maternal interventions and emergency obstetric care are necessary to manage complications that may arise during labor and delivery, reducing the maternal and neonatal mortality rates. This is the area which we have to focus a little more. Heart health for women. We have to break the gender gap. Historically, we used to think that heart disease has been primarily a man's health issue. But remember, heart health for women is a critical area that often faces significant disparities and misconceptions, leading to a gender gap in awareness, diagnosis, and treatment. Actually, cardiovascular disease is the leading cause of death for women globally, highlighting the urgent need for gender-specific approaches to prevention, diagnosis, and management. One key challenge is the underestimation and misinterpretation of symptoms in women. While chest pain is a common symptom in men, women may experience subtle signs such as fatigue, shortness of breath, nausea, or discomfort in the jaw, neck, or back. Now, these differences can lead to delay in seeking medical help and receiving the appropriate treatment. Risk factors for heart disease in women include traditional factors like high BP, high cholesterol, smoking, and all those things, plus mental health conditions like depression, chronic stress also. Estrogens and genetics in women result in different clinical presentation of CVD in women. Women may present more commonly with unstable angina, whereas men with acute ischemic syndrome. In women, again, a vascular dysfunction involves not only large coronary vessels, but mainly the smaller ones. That's called microvessel disease. This cannot be seen even in angiogram. The Women's Ischemia Syndrome Evaluation, that is why study explains this, and the investigators are working to develop a newer system for screening women for heart disease. Now, women's health and chronic disease management are interconnected aspects that require comprehensive, integrated approaches to promote well-being and quality of life. Cardiovascular disease, including heart disease and stroke, is a leading cause of death among women worldwide. Prevention efforts focus on lifestyle modification, including healthy eating, regular exercise, smoking cessation, managing stress, alongside medical interventions. Nutrition plays a crucial role in promoting women's health and well-being across all stages of life, from adolescence to menopause, and even beyond. Key nutrients which are important for women's health include calcium and vitamin D for bone health, particularly important during adolescence and menopause when bone density may decline. Iron is essential to prevent anemia, especially during menstruation, pregnancy, and lactation. Of course, folic acid, we all know about the fetal involvement. Now, initiatives like Jal Jeevan Mission for providing clean tap water, Swachh Bharat Mission for sanitation, and Poshan Abhiyan provide clean water, sanitation, as well as maternal child nutrition. Now, mental health and well-being is another area which we have to focus. Women's mental health and well-being are crucial aspects of overall health that influence their quality of life. There are various factors that can impact women's health and mental health, like biological, social, and environmental factors. Biologically, the hormonal changes during puberty, menstruation, pregnancy, and menopause can affect women's mental health. Postpartum depression is a notable example. Additionally, women are more susceptible to certain mental health conditions, such as depression and anxiety disorders, compared to men. But these are all the things which we have to keep in mind when we approach women while treating them. Addressing women's mental health requires a holistic approach that includes access to mental health services, education, and support, awareness campaigns and initiatives aimed at reducing stigma surrounding mental health issues is very essential. We have to encourage open discussions about mental health and provide resources for seeking help, which are the critical steps for promoting the well-being. Gender-based violence and women's health. Again, this poses a significant threat to women's well-being, which encompasses physical, sexual, psychological, as well as economic harm. It includes acts such as domestic violence, sexual assault, trafficking, harmful traditional practices like forced marriage, female genital mutilation, all those things. Now, this undermines women's rights, autonomy, physical safety, and often leading on to long-term physical and mental health consequences. Now, psychological effects may include anxiety, depression, post-traumatic stress disorder, and suicidal thoughts even. And of course, it can increase the risk of sexually transmitted infection and unwanted pregnancy and reproductive health complications. And now, how are we going to tackle that? So, prevention requires a multifaceted approach, which includes legal reforms, policies to protect women's rights, community education, and changing societal norms that perpetuate violence. Empowering women economically and promoting gender equality are also very essential in reducing vulnerability to this gender-based violence. And women's health, research, and innovation are essential for advancing healthcare outcomes and addressing gender-specific health disparities. Historically, medical research has often focused on male subjects only, leading on to gaps in understanding how the diseases manifest differently in women and men, as well as differences in the treatment responses. Research initiatives focused on women's health aim to fill these gaps by studying sex-specific differences in disease prevalence, symptoms, risk factors, and treatment outcomes also, like heart disease, autoimmune disorders, mental health conditions, and cancers, which affect women uniquely. Innovations in women's health research can encompass a wide range of disciplines, from biomedical sciences and genetics to public health and behavioral research. Advances in technology such as genomic sequencing, personalized medicine, and digital health tools hold promise for tailoring treatments to individual women's genetic profiles and health needs. Holistic approaches to women's health encompass the integration of mind, body, and soul, recognizing the interconnectedness of these facets in achieving the overall well-being. This approach emphasizes treating the whole person rather than just the symptoms alone, promoting health from a comprehensive standpoint. Many of us are practicing like that. We are all the family doctors to the patient, so that then we not only treat the patient's disease, but also we counsel them for all their mental problems or any psychological issues, the family problems, and so many things. We help them. And mental health plays a crucial role addressing emotional well-being through practices such as mindfulness, meditation, and therapy. And these methods help manage stress, anxiety, and depression. Spiritual health acknowledges the importance of spiritual practices in fostering inner peace and connection, whether through religion, nature, or personal reflection. Nurturing the soul contributes to a sense of purpose and fulfillment. This we have to accept. Holistic approach encourages self-care practices like adequate sleep, relaxation techniques, and self-compassion. These habits are essential for maintaining equilibrium and resilience amidst life's challenges. Regular physical activity not only strengthens the body, but also enhances mood and reduces the risk of chronic diseases. Now, this not only we have to encourage our patients and other women, but also we have to follow that. Now, who will like to be like this? As and when we age, even though we may be getting such difficulties, but when we find it difficult to get up from the chair, we feel very bad. But for that, we need some exercise for the muscles. We have to do the exercise like this, which should be done regularly. But remember one thing, even in this patient, girl, she is not just keeping her hand down. Actually, the hand should be kept across the chest. And is it very difficult to do this? It is a easily doable exercise, which every one of us can do it. I'll just show you a small example of this, how we can do this. Day to day, you can do this. Very simple exercise, similar thing we can do. Is it not very easy? And women's health disparities, achieving equity, that is again very important. It is crucial because this disparities persist across the various dimensions, impacting access to quality care and health outcomes. Socioeconomic factors like income, education, and employment status often intersect with gender, race, and ethnicity, leading on to inequalities in health also. Access to healthcare services is a significant issue. Lack of insurance coverage and inadequate coverage further exacerbate care and timely treatment. Reproductive health disparities include disparities in access to contraception, family planning services, and prenatal care. And these disparities can result in higher rates of unintended pregnancy, maternal mortality, and adverse birth outcomes. But of course, our government is doing a lot focusing on these areas, and we are carrying it over in our own places. And women's health and digital age. This being transformed by advancements in technology, offering new opportunities to enhance care, access information, and empower individuals in managing their health. Mobile apps and wearable devices enable women to track menstrual cycles, monitor fertility, and manage reproductive health, convenience, and accuracy. Telemedicine has revolutionized healthcare delivery, providing virtual consultations for routine checkups, follow-ups, and sensitive issues like sexual health or mental well-being. This accessibility is particularly beneficial for women in rural or underserved areas who may face barriers to in-person care. Digital platforms can also support education and awareness campaigns on women's health topics, ranging from prenatal care and menopause management to breast cancer screening and pelvic floor exercise. Really, it helps us a lot in creating awareness about health among the women. These resources empower women to make informed decisions about their health and engage actively in preventive care. And building resilience in the face of women's health challenges is again essential for navigating the complexities of physical, mental, and emotional well-being. Women often encounter a range of health issues throughout their lives, including the reproductive health concerns, chronic conditions like autoimmune disorders, mental disorders, and so many other things. Now, physical health challenges such as fertility issues, pregnancy complications, chronic illnesses, all these things require resilience to cope with treatments, setbacks, and lifestyle adjustments. Women themselves, they should know, and we also should support them. Developing a proactive approach to self-care, including regular exercise, Balanced nutrition and preventive screenings can empower women to manage their health effectively. Building coping strategies such as mindfulness therapy and support groups fosters emotional strength and reduces the impact of psychological stresses. Navigating societal expectations and cultural norms around women's health can pose additional challenges too. Now, I always love this IMS slogan. You should be fit at 40 like this, strong at 60 like this, and independent at 80. You can do anything. You should be able to do anything. And healthy at 100, like Vaijayantimala dancing like this, even at the age of 90, I think 96 or so. So, to conclude, women's health is nation's wealth. It is not just about addressing the needs. It is about unlocking the potential and enabling empowerment at every stage of life. Let's all join together to commit to create a future where every woman's wellness is prioritized, every voice is heard, and every promise for a healthier tomorrow is fulfilled. Together, we can and we will build a world where women's health is not only a goal, but a cornerstone of progress for all. Thank you very much. Gayatri?
Yes, ma'am.
Yeah.
That was a wonderful thing, ma'am. I don't think you missed anything in the women's health update. Thank you very much, ma'am. It's always been a pleasure to listen to your talks. Then with this, we go on to that last session of today, where we have a panel by Dr. Hepsiba Kripavani, who does not require any kind of introduction to our stage at all. She's got so many things to her credit. She's the past president of OBG in the OBG Society of Southern India. And she's held a lot of very important positions in a lot of societies and chapters.
Yeah.
She is...
Skip, Dr. Gayatri. We'll
Yes,
move on to the panel. You can, it's my proud privilege to participate in TNFOG CME. Thanks to Dr. Ramani Devi, Dr. Sampath, and after listening to Dr. Revati Madam's talk, it's really, really wonderful. She started right from small things to exercise to the digital health. And after this, we will move on to an important topic, which most of the people are suffering nowadays. I have a very brilliant, young, enthusiastic panelist, Dr. Deepa Pangalam. Can I have the next slide? She's an assistant professor. And Dr. Devi Lakshmi, assistant professor, Department of Obstetrics. And Amuda Ambigai, she is graduated from Keel Park, Madras Medical College, and she has got a lot of experience. Her field of interest is reproductive medicine. And Dr. Mageshwari, undergraduate, postgraduate from Tanjavur Medical College, practicing at Pattukotai. Yes, we have a brilliant team. I think the first ground rules is I will ask questions and no one should ask questions to me, right? So with that, we'll move on to the topic.
Good evening, madam.
Good evening.
Good evening, madam.
Good evening, good evening, good evening. Are you able to see my slides? Are you able to see my slides?
Yes,
ma'am.
I always think the postmenopausal bleeding is a red flag. And we have a wonderful panelist, a brilliant panelist to teach us something about postmenopausal bleeding. The significance of postmenopausal bleeding, whether it's a slight, it may be, it should not be underestimated, as many as 1/3 of the cases are due to malignancy. And to recapitulate, just for the youngsters, the PGs might have joined, and for them to know the definition, postmenopausal bleeding occurs after at least 1 year of amenorrhea without any contributory factor for amenorrhea. And recurrent postmenopausal bleeding, although there is no consensus for the definition of recurrent postmenopausal in the literature, any bleeding occurring following a negative initial investigation or any bleeding episode separated by a period of without bleeding. So we will move on to the first question. Can you tell me about what are the various causes for postmenopausal bleeding? Yes, doctor? All of them have joined, no? Hello?
Yes, ma'am.
Yeah, please go ahead. Dr. Amuda, anyone can. What are the various causes? All four of you have joined. They are still muted.
Yes, ma'am. Joined, ma'am.
Ma'am,
Postmenopausal bleeding.
Change their name in the profile. We don't know if they joined or no. It's all coming as doctor. We don't have their names here.
They can rename it. Go to your photo.
Yeah,
On
madam.
the right hand side, you click it. That it will show. Rename. Okay, go ahead, doctor. Who has joined? Amuda, Mageshwari, Deepa.
Ma'am, there are various causes of postmenopausal bleeding.
Yeah.
It could be a local cause.
Yes.
Or it could be from the uterine.
Yes.
It could be most common cause will be due to hormonal changes. It could be atrophic vaginitis or atrophic endometritis. And local causes could be cervical erosion, cervical polyp, and from the uterus it could be a uterine polyp because of a uterine polyp, a submucosal fibroid, and endometrial hyperplasia, and could be cancerous causes like endometrial cancer, CA cervix, and also patients on hormone replacement therapy because of hormonal changes, ma'am, or
Yes.
any trauma.
Yes.
Bleeding from nearby structures also, ma'am.
Ovarian pathology, a functioning ovarian tumor can also cause adnexal pathology. Very rare causes of tubal carcinoma can also have a postmenopausal bleeding. And sometimes this pruritus vulva due to vulval dystrophy is also present to us as postmenopausal bleeding. And as you rightly said about menopausal hormone therapy and some medication at anticoagulations like that also sometimes can cause postmenopausal. Okay. How will you evaluate a woman with postmenopausal bleeding? Yes, doctor.
Hello.
Yeah. Please go ahead. A patient comes to your clinic. How are you going to evaluate her?
First, we have to ask about the history, ma'am.
Yes, wonderful.
Any history of trauma or any history of abdomen pain?
Yes.
And any history of bleeding diathesis or family history of cancer, obesity, and thyroid.
Both personal history, family history, drug history, any surgical history.
Any and any use of HRT like hormones, anything
Yes.
she has used.
Yeah, previously, whether she was treated for polycystic ovarian disease. And of course, we have to know about the timing of menopause and her age and her parity. Certain things are more common in nulliparous, certain things are more common in multiparous. So all this detailed history, a personal family history and drug history is very important. And followed by, we may have to do physical examination because within 4 weeks, if the patient has endometrial carcinoma, it can flare up, I believe. So it should include, similarly, the examination also should include a general examination, per abdominal examination to assess the entire lower genital tract, as many patients will have a non-endometrial causes for bleeding, just and vulval, vaginal, cervical pathology. We have to do the thorough clinical examination, both the general and the gynec examination.
Gynec examinations.
What are the investigation you would suggest for this patient presenting with postmenopausal bleeding?
After doing a complete.
Yes. Yeah, go ahead, doctor. Go ahead.
After doing a complete evaluation about the history
wonderful.
and investigations, and we have to we can go for an DECA procedure like Whipple curating.
pulcurity. And then after the results, we can
Any
plan for
non-invasive you can do before
like a scan. We have to do first a scan to rule out endometrial thickness.
Yes.
And any collection in the uterus.
Yes. Yeah. Sometimes a cervical stenosis can cause, due to cancer cervix, even it can cause pyometra also. Yes. Yes, doctor.
And
For all cases, will you suggest CT and MRI?
First speculum examination.
Yes, doctor. That comes under examination. So, investigation, the first and foremost, we have to do
complete blood count, ma'am. Coagulation study.
Yeah, if she
Coagulation
can't
studies.
anticoagulant therapy, we can do the coagulatory profile also, a PTT and PTT, just to know about her status. And if she has some liver pathology also, we can do it. And the first and foremost, first line of one-step procedure, we can, after doing an gynec examination, we can do an ultrasound. Most of us are having an ultrasound in the office.
Transvaginal ultrasound, madam.
Yeah, and followed by office procedure-based endometrial biopsy. And it's better to, so we have, it's very good idea to have a Doppler in addition to transvaginal, because by the distribution of the blood vessel itself, we know whether it's a benign or malignant. And in benign, it is scattered blood distribution. And it is very global, as you see in this. Hope you are seeing the pictures, no? You're able to see the picture? Hello?
Yes, ma'am.
Yes. It's a global pattern. In malignancy, it is very much scattered in benign. We'll have some idea about the nature of the disease. Okay? So many of us are having ultrasound in our office. And can anyone tell me how to measure endometrial thickness in transvaginal sonogram?
Ma'am, in transvaginal ultrasound, it's better to measure it in the longitudinal axis, madam.
Yes.
The long axis.
Sagittal.
And depending upon the phases, it differs.
Yes.
And usually we have a triple layer. And so from the bright triple layer, in the middle, we have a bright line. And adjacent to the bright line, we have dark areas. And in the endomyometrial border, that will also be bright. So from anteriorly to posteriorly, we have to measure, madam.
Yeah.
From the endomyometrial interface.
Yes. That is endometrial myometrial junction is here. Okay. So the endometrial thickness should be in the sagittal plane, and you must view right from the fundus to the cervical canal. It should be like this, so that you can measure this. Suppose there is some fluid, we should avoid it, right? Okay. So what is the risk of endometrial cancer and endometrial thickness?
Endometrial cancer in the developed countries is 30%, madam, occurrence. Whereas India is a developing country, here next to cervix, cancer cervix, it comes to 5 to 7% endometrial cancer, ma'am. It occurs in old age after 50 years, 75% its occurrence is there. And commonly it occurs by 60 to 70 years of age group. It's actually the risk factors of endometrial carcinoma is unopposed action of estrogen.
No. In relation to endometrial thickness, doctor, actually, suppose in postmenopausal bleeding, the commonest cause we have to do in our setup is the cancer cervix. For want of time, now we are seeing postmenopausal bleeding also common because of the obesity and PCOS. So I want of time, I just focus on endometrial cancer.
Endometrial thickness should be more than 4 millimeters. More than 4 millimeters, it is taken as.
So based on thickness, the risk also increases. Right? When it is less than 3, it is only 1.3, 4, like that it increases. And greater than 4 millimeter, it is without bleeding also, we have to routinely evaluate it. And in one study, they said the endometrial cancer is 10%. Probably the disease of endometrial thickness threshold varies. 5 millimeter is 2% and 4 millimeter 1.2. And like that. So the more the thickness, the chances for malignancy we should suspect. what is the preferred method to get endometrial sample? What is the accuracy of pupil biopsy?
Ma'am, pupil biopsy is my easiest
Ideal method is an
for
office procedure.
office procedure. It is
Yes.
most probably painless, and the patient can go home.
Go
And
home, it takes
it's
hardly few
on the same
seconds.
day. Yeah, if
Something
you
like
take
one-stop
seconds.
method, you know, we can do. Yeah, do an ultrasound.
Yeah, it
Yeah, go ahead, doctor.
and about sensitivity is about pupil biopsy is about 97% and specificity is more than 98%, madam.
Yes.
So it increase in patient acceptance is there.
Yes.
And mostly
It's
adequate
most
tissue sample
convenient
in
also. With one stop, we can do at TVS, and the same day we can do endometrial
same day, same
biopsy
procedure on the same day.
And it's more cost effective also and efficient.
Cost effective also. Yes, ma'am. Yes, ma'am.
Okay, thank you. And why do you, when do we proceed with office histoscope?
While doing pupil
Office
biopsy,
histoscope is very
when we
steep.
don't
Yes.
office when we don't get a sample while doing a pupil biopsy, or the sample is inadequate for diagnosis,
Yes.
or even when the endometrium thickness is less than 4 mm, but the patient is having recurrent bleeding.
Yes,
and
wonderful.
patients on tamoxifen,
Yes.
for them we don't do blind biopsies, we do only hysteroscopy guided biopsies, ma'am.
Yes.
In such cases, we proceed with hysteroscopy guided biopsies. Office hysteroscopy is also done under, as OP procedure, ma'am.
Yeah. At the same time, in some case, it can be a both diagnostic and therapeutic.
As well as therapeutic, yes.
Okay, and sensitivity is 86.4% and specificity is 99.2%. Okay. What is the disadvantage in office hysteroscope? Is there any disadvantage?
It's an outpatient procedure, madam, but sometimes it can lead to vasovagal reactions also.
Yes.
And in cases of cervical stenosis
yes.
or abnormal position of the uterus, if there are
Yes.
any previous surgeries, it would be difficult, madam.
Yes, we may not able to get into it, but now with the help of mesoprost, we can insert mesoprost after some time we can. Even when there is a stenosed or this thing, we can do it also. But sometime when there is a difficult discomfort and the patient is having intolerance to pain, it's better to shift to the conventional histoscope. Sometime we may, when previous LSEs are acutely and retroverted or something, we may not reach the uterine cavity. That is the disadvantage. Right. So, is there a risk of tumor dissemination following a hysteroscope?
There is a theoretical risk, madam, but still, if pressure is maintained less than 70 millimeters mercury, no spillage has been reported to occur.
They have done a long-term follow-up also for there is it is not associated with the staging is not upgraded or it's a worse survival also is there. Theoretically, we feel a little uncomfortable. After negative initial investigation, when to do further investigation? Suppose the patient comes to you and it shows atrophic endometrium. What is your advice you will give? How to counsel her? Yes, madam.
If the patient is having recurrent bleeding, ma'am.
Yes. Actually, there is no guidance. There is no guidelines. After 3 months, you have to do after 6 months. We have to counsel them depending upon, suppose she is a high risk, diabetic patient, obese patient, hypertensive. There is a family history. She has to, though it is negative, we need to have a close surveillance. So it should be appropriate to ask her to come after 3 months, even that there is no complaint or no bleeding, and advise her to review whenever there is a bleeding. There is no cutoff or guidelines, consensus of so far they have not come. And a word of women with postmenopausal bleeding on menopausal hormone therapy. If it is 4 millimeter, invariably it is a high false positive rate it can given. And interpretation of endometrial thickness should be related to. Actually, she was talking about triple line and all. That is more often in reproductive age group we talk. But here also we have to time the endometrial thickness when they are on menopausal hormone therapy. Ideally 5 days from the end of progesterone phase, or any time in continuous, when the patient is on continuous combined therapy, any time we can do it. When the patient is on sequential therapy, at the 5 to 10 days from the end of progesterone phase. It's unnecessary to evaluate the endometrium of women with uterine spotting beginning of first 6 months of continuous combined therapy. There will be some amount of spotting will be there. So first 6 months, we need not worry. If women on cyclical MHT, the withdrawal bleeding outside the time of progesterone therapy should be evaluated. This we have to keep it in mind. So we'll move on to the case. 50-year-old woman, para 3, BMI 20.9, with no comorbid condition, has postmenopausal bleeding, and the endometrial biopsy shows proliferative endometrium. What will you do? There's no malignancy and you're happy and you'll send her off. Yes, madam?
We can advise the patient to review after 3 months, and medical management with Meprate also can be started, ma'am.
Postmenopausal lady.
With
Yes.
Suppose if it is an
will you go on to give Meprate for postmenopausal lady? Though it is proliferative phase, there is some amount of endometrium, estradiol secretion there. And she is prone for endometrial
carcinoma.
Okay. So there is endometrial carcinoma, 5.8%, so it's 1.44 increase. So
about 6%.
Depending upon her risk factors, obesity, family history, all those things we have to, carcinoma happens 5 or more years after initial diagnosis of proliferating. So it's better we have to counsel her and informed choice. She has to take a decision. You have to give a non-directional counseling, right? So next case, a 48-year-old para 2 obese postmenopausal women, BMI 25 kg meter square with no comorbid condition. She has postmenopausal bleeding. Endometrial biopsy shows endometrial hyperplasia without atypia. What will you do? Risk prognosis to endometrial.
If she is with endometrial hyperplasia without atypia, means
without atypia and with atypia.
First, I'll counsel the patient, madam. I'll say the risk factors. Then she'll be going for atypical changes later on. Because endometrial hyperplasia without atypia will convert into atypical changes after a period of 20 years. So I'll counsel her, and if she's bleeding, I'll first line, I'll counsel her for levonorgestrel intrauterine system for 5 years continuous, or I'll give oral progesterone 10 milligram TDS for 6 months, ma'am.
No, postmenopausal bleeding, which will you offer her?
Otherwise, I'll counsel her for hysterectomy, ma'am. As she is
it's always safe to counsel her postmenopausal woman requiring surgical management, endometrial hyperplasia with atypia or without atypia. You do not know which percentage she is going to fall. Even if it is a 0.05%, she will come and going to shout at you. Okay. So it, as theoretical thing, it takes 20 years without atypia. With atypia, it is frequent. So better you counsel them, and if there is a risk factor,
I'll go in for total hysterectomy with bilateral salpingo oophorectomy, ma'am.
Yes. Good. So another case, 50-year-old asymptomatic on routine investigation, has endometrial thickness 7 millimeter with BMI 19.5 without comorbid condition. How will you manage?
Ma'am, the ET is about 11 millimeter. So we have to go for biopsy, ma'am. Like
Yes.
we can
According to the
proceed to-
guidelines, whenever you see a thickened endometrium or increased vascularity, inhomogeneous endometrium, particulate fluid, we need to have, we just cannot send around. You have to do further evaluation. So move on to the next case, 48-year Paris. Complaints of postmenopausal bleeding without comorbid condition has come to you with a report suggesting of endometrial polyp. And they have written correlate with clinical findings. Physical examination and gynec examination is normal, and pap test also negative for intraepithelial lesion. What will you do? Yes, madam. Mageshwari, Deepa,
Polypectomy can be done, ma'am.
Pardon, doctor?
Polypectomy, madam.
Straight away you will go. They have given suggestive of endometrial. Any other investigation you will order? Before endometrial biopsy?
Cystoscope.
And
Yes,
what
ma'am.
percentage of- Usually the polyp
Can
is
go
very
for-
common nowadays. It is around 37%.
Yes,
Okay. So what investigation will order before endometrial biopsy? Of course, they have given only suggestion. Anything else you can do?
saline infusion sonography, ma'am.
Yes, saline infusion.
Sonography.
Of course. And you have to ask for Doppler.
Doppler.
Doppler gives an idea about the vascular pattern. As I already told you, when it is global, it is malignancy. If it is scattered, it is benign. And endometrial, there is one sign called pedicle artery sign or single vessel pattern. That is the pedicle. So we are sure about that it is endometrial polyp. Here, it is something like ectopic. A rim-like Doppler pattern is seen. And it may be due to submucous pattern. So it's worthwhile doing a Doppler before endometrial biopsy. You can have a mental picture what you are dealing with. So what is the role of CT and MRI in this condition? Will you suggest? With that Doppler and other things, will you suggest CT and MRI?
If there is any suspicion of malignancy, ma'am.
Lymph node metastasis.
There is suspicion of
Actually, it
malignancy.
doesn't give, when there is a polyp, it doesn't give some more investigation. Doppler gives lot of information. So what will you choose? Office histoscopy or conventional histoscopy? What are the goals in histoscopy?
Conventional histoscopy can be used.
Yes, yes. So
It is-
that helps a complete resection and reduces the recurrence. And of course, we can get a pathology specimen also. We'll move on to the next case. 50-year-old nullipara, because nowadays we see a lot of postmenopausal bleeding and confining to endometrial carcinoma. And few newer things also have come on staging. BMI 25.5, diabetes with postmenopausal bleeding with endometrial thickness 12 millimeter and endometrial biopsy report, endometrioid adenocarcinoma. What are the pre-surgical routine evaluation you will do? Endometrioid carcinoma, adenocarcinoma.
Routine investigations, routine blood investigations, ma'am.
Yes.
Pre-surgical
Yes.
investigations.
Yes.
The complete blood count, sugar, renal function test, and liver function test, ma'am.
Yes.
And for invasion, we have to do an MRI, ma'am, to check for the myometrial invasion, cervical involvement, lymph node involvement, ma'am. And
Yes.
And we can go for CT chest and abdomen pelvis, ma'am.
For all case you will do.
In high grade, ma'am. Only in high grade we do.
High grade, and we suspect something. And sometimes the CA125 not routinely done, but in the guidelines they say when it is
For
high,
follow-up.
it indicates the distant metastasis. Not for all cases, we do MRI and PET.
Okay, ma'am.
What is the importance of FIGO 2023 classification?
We have included the histological grading also, madam.
Yes.
In FIGO 2023 classification.
Yes.
And involvement of ovary, it has come under stage 1.
Yes, it has been divided into aggressive and non-aggressive. Non-aggressive histological type. It is an endometrioid carcinoma. And non-endometrioid carcinoma is always aggressive. In addition, molecular classification has been done. So FIGO 2023 revision has led to different classification and management strategies. See, the management strategy for endometrial carcinoma and non-endometrial carcinoma is a little different in staging and other things. This is for stratifying the prognostic risk group and guide the treatment decision also. So that is the advantage in that newer classification. Okay. When will you consider sentinel lymph node biopsy?
Sentinel lymph node is a primary node, madam. First node to be affected. When dye is injected near the tumor, it is mostly used in carcinoma endometrium, ma'am. It is considered for surgical staging of the uterine lesion, madam, conferring malignancy, and there is no metastasis demonstrated by imaging studies. When it cannot be found in imaging studies or no obvious extrauterine disease is present. For the central lymph node mapping is used nowadays. The dye is taken up by the lymph node, primary lymph node, by which we can identify the distal metastasis and treatment can be proceeded, ma'am.
Yeah. So this is to rule out the occult lymph node metastasis in a low risk and intermediate risk and avoiding unnecessary extensive lymph node this thing. And it can be omitted when there is a myometrial invasion. When you suspect, you have to omit this. And mapping has been shown to offer high sensitivity and specificity. Not only it's even sometime when we do an extensive lymphadenectomy, it causes morbidity, lymphedema, lymphocyte formation, and all these things can be prevented by sentinel lymph node biopsy in cases to low risk and intermediate risk to rule out occult lymph node metastasis.
It should be done prior to hysterectomy, ma'am.
Of course. Is there difference between laparoscope and laparotomy in rates of disease-free and overall survival rates?
Ma'am, actually, according to the studies, there is no significant difference in the overall survival and disease-free survival rates between laparoscopy and laparotomy, ma'am.
Yes, there's a Cochrane systemic review. They have analyzed open laparoscopic surgery, either total laparoscopic hysterectomy or assisted for early stage of endometrial carcinoma.
Early stage, in the case of early stage, yeah.
Difference. But when you try to remove, it should be removed in back. When you do a total, even TLHS, it shouldn't cut into pieces and remove. All that should be
It should be taken in toto.
Avoided. It should be taken out in toto. How does myometrial invasion affect the prognosis of endometrial carcinoma?
Yeah, depth of
yes, doctor.
Depth of invasion as it increases, ma'am.
Yes.
The lymph node involvement is also increased, and there is upstaging of the disease, and hence the prognosis will get poorer, ma'am. Less than 50% myometrial invasion, 5% lymph node involvement will be there, and more than 50%, if it is there, lymph node involvement will be 20%, ma'am. So the grading and of tumor and the risk increases, ma'am. So prognosis will be poorer.
Yes. As the grade of tumor increases, usually occurs in depth of myometrial, rightly pointed out by you. exemption exists in that grade 1 lesions can have deep, sometimes grade 1 also will have deep myometrial invasion. So myometrial invasion is, we need to note for the prognosis. How does histological differentiation affect the prognosis of endometrial carcinoma?
High grade, and we have high grade and low grade tumors, madam.
Yes.
And it denotes the aggressiveness, madam. Endometrioid carcinomas and non-endometrioid carcinomas. The non-endometrioid carcinomas are more aggressive.
More
So
aggressive. As already pointed out, the FIGO 2023, they have classified non-aggressive and aggressive. So non-endometrial carcinoma are estrogen dependent, so they have a poor prognosis and they behave aggressive. Wonderful. What factors increase the risk of risk factors for lymph node metastasis in endometrial carcinoma?
The age of the patient more than 60 years, madam, and the size of tumor more than 2 centimeters, and the depth of invasion of myometrium will be more than 50%. And
Yes,
the grade,
wonderful.
More than grade 3, madam. These are the risk factors which for lymph node metastasis.
Yes. So it depends upon the poorly differentiated papillary serous and clear cell carcinoma. They all have a deep myometrial invasion also, the positive peritoneal cytology. Sometimes they have a, in addition, adnexal metastasis also. In those cases, lymph node metastasis will be there. So the peritoneal cytology is not included in FIGO staging, but see, all the oncologists, they do the peritoneal biopsy also, because it has got an independent prognostic factor and poor survival when there is a positive peritoneal deposits. It is not included actually in the FIGO staging. Okay. A 65-year-old multiparous woman with BMI 20 kg per meter square feet, no comorbid condition. What type of endometrial carcinoma you expect?
Most common endometrioid type, ma'am. Endometrioid?
Non-endometrioid.
Non-endometrioid.
And endometrial biopsy report comes as serous carcinoma stage 1. How do we manage her? This lady.
Stage 1B means TAH with BSO with brachytherapy, ma'am.
No, not necessary. She's one serous endometrial carcinoma. High, she comes under high intermediate risk. So we can do a intraperitoneal prevent. We have to prevent the interperitoneal tumor split during, as we already mentioned, we have to do a total hysterectomy, bilateral salpingo-oophorectomy. This thing and infracolic omentectomy should be performed in clinical stage endometrial carcinoma, serous endometrial carcinoma. So what are the molecular classification for endometrial carcinoma?
Molecular classification has been included in the latest FIGO 2023. Yes. 4 groups are there. One is fold mutation, and the other is mismatch repair genes deficiency, P53 abnormality, and the fourth one is no specific molecular profile. And the pole mutation is an ultra mutation with a very low number of copies, so it has a good prognosis, ma'am. P53 abnormality has a high number of copies, and so it has poor prognosis. Yes. And MMR deficiency and NSMP, they have intermediate prognosis, ma'am. Mainly for prognosticating and for adjuvant treatment, ma'am. Especially in the early stages.
Yes. It depends upon this. It will be either upgraded or low graded based on the molecular classification. But it does not include in FIGO stage 3 and 4. It is based only on surgical and anatomical findings. 1 and 2 only it is applicable. And we are nowadays, we are supposed to do, even with an endometrial biopsy, this can be done, molecular classification, so that you can plan the surgery. Very nice. What are the factors to predict recurrence?
Madam, these mutations, if there are some, these are biomarkers for predicting recurrence, madam. And there are 4 important factors: the size of the tumor, time from biopsy to surgery. If it is more than 6 months, it can lead to recurrence. And if the tumor size is more than 2 centimeters, if there is myometrial invasion of more than the inner half, and lymphovascular space invasion are also one of the predictors for recurrence, madam.
Yes. So it's mainly the histopathology, myometrial invasion, lymphovascular, and of course your aging. How to follow her up? You've done a surgery. How do we follow her up?
By imaging studies, madam.
Yeah. Patient should ask, you have to ask them to come for once in 3 months for first 2 to 3 years, and then every 6 months till 5 years. Okay. For the first 2 years and every 6 to 12 months thereafter, according to this NCCN, patients with low risk endometrial carcinoma can be followed less frequently, that is 6 to 12 months for the first 2 years, then early thereafter. When it is virulent, we have to follow up close follow after surgery. So we'll move on to we are coming to the end of the show. Rapid fire. Anybody can take it. What is the first step of investigation you will do when a patient comes with postmenopausal bleeding?
Transvaginal ultrasound.
Transvaginal ultrasound.
Both. Either transvaginal and office-based endometrial biopsy. Right. In which plane you measure endometrial thickness and how?
Sagittal plane. The maximum anteroposterior.
Yes. Wonderful. And which molecular pathology has got prognosis? Does molecular pathology alter staging in stage 3 and 4?
Cold mute has good prognosis, ma'am, and
Yes.
doesn't alter the inter stage 3, stage 4.
Right, wonderful. In which condition you will get rim-like Doppler pattern?
Endometrial polyp, madam.
No, submucous fibroid. Endometrial polyp is a single uterine vessel will be there. Single uterine artery sign, it is called. Okay, I think I have to thank the entire panelists for making it very lively. So the postmenopausal bleeding is a red flag. Mostly sometimes it need not to be atrophic endometrium, it can be benign. Polyp or due to MHT, due to medication, it can be there. But all gynecology services should be able to assess and investigate women with postmenopausal bleeding. And thank you for patient listening. And I thank profusely my panelists who has made my job very, very light. Thank you so much.
Thank you.
Thank you very much,
ma'am.
ma'am.
Thank you, ma'am. Thank you very much.
With this, we come to the end of the session.
Nice and crisp panel, Dr. Hepzibah.
Thank you, madam. Madam,
very, very practical, madam. You have covered.
It's wonderful, ma'am.
Thank you.
Requires an applause, ma'am.
Thank you. My panelists made my job very light.
Wonderful, madam. You have started from the base up to the immunohistochemistry for endometrial carcinoma. That is something fantastic. I think the current day, as gynecologists dealing with postmenopausal bleeding, we have to be thorough with all these things, including molecular diagnostic for endometrial carcinoma. Thank you, madam, for such a wonderful panel, madam.
This brings us to the end of today's Marathon CME. I would like to thank our chief guest and guest of honor for being here with us and blessing our program. I thank our judges who've been doing this very methodically in a very beautiful way. The Yuvas who participated in today's program. The talk, Dr. Revati Janakiraman for giving that wonderful Women's Update talk, and Dr. Chandra Ponusamy for the wonderful panel. I also extend my thanks to the delegates who logged in. It's for them that this program is. Thank you, Mrs. Sripriya, for all your event management and other things. Shield and Sahiti Priya for your support. Last but not the least, thanks to the Almighty for blessing us so far, and I pray that He continues to bless us. Thank you.
Thanks, Gayatri.
Thank you.
Thank you. Bye.
Thank you, madam.